Good afternoon and welcome to Department of Medicine Grand Rounds. My name is Ted Johnson. I'm the Division Director for General Medicine in Geriatrics. And wherever I go in the United States, there are two things people say to me. Hi, Ted, how are you? And the second thing is, please give my regards to Dr. Branch. And you'll see by the number of people that he has on this first slide listed as collaborators, that's definitely the case. Dr. Branch has a nationwide reputation in this field. We're very excited to have him here. Talk about Grand Rounds. His topic is medicine at the crossroads, business or profession. Dr. Branch is the Carter Smith Senior Professor of Medicine. He is a master of the American College of Physicians, and I think you're really going to enjoy this Grand Rounds, Dr. Branch.
Thank you, Ted. About a month ago, I celebrated my 24th year at Emory. It's been a wonderful time here, teaching, working with amazing faculty. And in the past 7 or 8 years, I've not had administrative responsibilities and enjoyed really the opportunity at my age to try to do creative work, which has been probably one of the most fun and productive periods of my career. And I also have to thank for the support to be able to do that. Ted Johnson, who's our division director, and Jada Bussey-Jones, the director at Grady. So it's been a great time, and part of what I've been doing is some multi-institutional studies of developing faculty across the country. This is one of those projects. The name I gave the talk is Healthcare at the Crossroads, which is what we gave to one of the papers. And I've listed here the collaborators in this particular project. Some wonderful people, many of whom I've known for a long time. Others I met by picking them to be in the project, and they've all contributed, especially Richard Frankel, who has been with me for a long time, and Richard Pittman, who's helped a lot at Emory. So I'm going to talk about the development of physicians and what happens and the struggles they go through in the current environment that we have evolved to at the moment, and also about perhaps where we may be going. The premise for this is that medicine is a moral enterprise, and it is guided by standards that require sacrifice and emotional energy to achieve the respectful, compassionate, culturally sensitive humanistic relationships that are therapeutic for patients, families, and others. To help physicians approach these professional standards, it is important to understand factors that sustain and impede them. For example, burnout, reflecting stress in the practice, has become endemic among physicians. So we are at the crossroads. Now, we've talked a lot about medical humanism and professionalism here, about how to develop that. And everyone wants a definition. This is my favorite definition from Jordan Cohen, who for many years was leader of the AAMC. Professionalism denotes a way of behaving in accordance with certain normative values, whereas humanism denotes an intrinsic set of deep-seated convictions about one's obligations towards others. Viewed in this way, humanism is the passion that animates professionalism. The two are intrinsically linked. How to develop people who become really highly developed professional and humanistic physicians. Well, we have a faculty development program which I will talk about later. And from that program, at 7 of the medical schools, we asked 68 graduates of the program to participate in this study, in this series of studies. All had completed the one-year faculty development program that we designed to enhance humanistic teaching and role modeling. All were selected by leaders at the school that they were from a pool of applicants who were clinical teachers and practitioners. They all attended twice monthly experiential and reflective learning sessions for 1 year. 59% were female, 69% were less than 45, 85% were at the junior faculty rank. About half of them were primary care physicians. So that gives you a sense of who the study population for our studies are. We will quote other studies as well. So we asked this group of physicians, what sustains you? What is it that helps you to sustain your humanistic practice? And I'm quoting here from one single quote, which, as often happens in these narrative quotes, illustrates about 5 of the major themes that we accumulated under sustaining. When I was a child diagnosed with a certain disease, very shortly at age 7, when doctors treated me with respect and compassion, I wanted to emulate that. I was interested in how the physicians spoke to me. My role models were those doctors who treated patients humanistically, and I became very interested in working with children whose medical and developmental issues made it harder for people to recognize their humanity. Practicing humanistically means forging a connection with each patient and family as a human being. As I work with students, residents, fellows, and faculty, it is important to me to share the joy of making these connections. It is through modeling and discussion that I try to help students. So here we have the theme of someone who is influenced by having experienced an illness, who is influenced by important role models and becomes a role model, who forges a connection, which we call a therapeutic relationship. And that includes a deep understanding and an emotional connection, as well as knowledge of the patient. And most importantly, it is who I am. And this is one thing that we are looking at throughout. Who I am, the professional identity of the faculty member. And we're very interested in that as what we're trying to develop. We'll come back to that throughout the talk. So many illustrative phrases were quite similar to that long quote in expressing what it was that kept them sustained in practice. It is truly at the core of who I am. I was raised to do the right thing. I wanted my children to see me as a good person. And on and on. The memory of my best teachers and care providers is vivid. I hope to provide that to others. If one believes clinical care is of utmost importance, external issues go to the background, and patients are treated with one's full attention and the respect that they deserve. This is mindful practice. But we have a practice environment today which is on the other side of this. It's the other question, what impedes you? And I think what we discovered is it is the chaotic practice environment. A focus and emphasis on productivity, performance metrics, and documentation, which we will come back to later. Physicians spending less time with patients than with the electronic medical record. As Margaret Klusogen, one of my collaborators, wrote in one of the papers, technological advances influence what we can do to patients. But much of what patients want and expect falls within the realm of being with patients when they are suffering, listening, helping with difficult decisions, and navigating their illness trajectories. So what we see is a dissonance between the humanistic values of the physicians and the business aspect of medicine. And what we need to do is find a way to bring those together. We can't have medicine unless it avoids bankruptcy. At the same time, we can't be physicians unless we can be humanistic. So we have an imperative here, and in some way it is drifting apart rather than coming together. For the health professionals, there is work overload, there is stress and dissatisfaction, as we have seen, a loss of resilience, diminution of well-being, professional burnout, and finally, the major point here, incongruence between personal values and the health system values, something that has to be overcome. The barriers, another long quote which gives us several of the major themes, two major themes or three major themes. This physician says, honestly, personal fatigue, feeling drained of my own spirit and not feeling like I have anything to give, being judged by hospital administrators by crude metrics, etc. Let's see if I can make this work. Oops, didn't work. I'm having a little trouble here. Wow. We really got out of sync here. Can you get me back to where I was? I don't know what happened. There we go. Yeah, I was trying to use this as a pointer, but it doesn't.
Yeah,
there.
your point right there.
All right. I apologize for the lack of technical expertise. So this is where I was. I wanted to skip down here and say I am scored by the pressure to hit these marks, which qualify me as good or bad. This can fuel a need to be technically perfect more than compassionate and empathetic. This might mean I spend less time with patients and feel rushed with learners. So what we see are some major themes here. Time, bureaucratic culture, as opposed to the humanistic culture, and stress. The stress of lack of time and the chaotic practice. And as one of these physicians said, when asked to comment on this, just said, time, time, time. The chaotic practice includes, could be defined by these quotes taken from the physicians. Again, time, resources, paperwork, intrusions of the electronic record, checklists, distractions, fatigue, demoralization, A difficult patient at the end of a busy day can be a burden. Drained by heartbreaking situations. Now, this is what we're supposed to deal with. But these physicians are drained by the stress and the time pressure and the paperwork. A perverse culture that fosters cynicism and anger. Surrounded by colleagues who are burned out. I have also been burned out. A culture that values productivity over humanistic care. These are just some of the illustrative quotes we took. And I think it does define what some people have called a chaotic practice environment. So what did we find? This quote from one of our papers sort of illustrates what we found. We found people that were determined and dedicated to practicing the kind of humanistic medicine and building the patient relationships that they had been taught. And we found that they were having a lot of trouble succeeding in doing that due to all the pressure that was on. So how did they respond? They portrayed themselves as isolated individuals, heroically placing their fingers in the dike and hoping that their individual humanism would save the day. We feel that is somewhat futile. I mean, it will lead to burnout. So what was the response of the institutions? The institutions responded, for the most part, by seeking to enhance resilience in the physicians. The ability to maintain personal and professional well-being in the face of ongoing stress and adversity. This assumes that work will contain challenges, and it requires an ability to face the challenges and adapt. You should learn from your errors. Got that same problem. Can you get me out of this again? I'm just clicking. Thank you. So we're on resilience. And this is a definition of resilience. I'll just read the main features. A positive worldview. Finding meaning beyond oneself. Seek support through close relations. Coping and self-care skills. Cope with stress in healthy ways. Avoid harmful coping. Self-awareness and self-management. Managing strong feelings and impulses, communication skills, and mindfulness. Well, we wanted to develop the best faculty development program that was possible. So we started off to do that with this multi-institutional longitudinal faculty development program, and it is aimed at creating all of the factors that I just listed under resilience. Group support, meaning, something larger than yourself, self-awareness, communication skills, all of those things. To do that, we thought we needed a program that would last for 1 year. We began in 1999. I began with a group of colleagues. And by 2017, we had done the program at 30 U.S. and Canadian schools, of which some of them had done the program for classes of faculty at least 8 or 10 times. 993 faculty had completed the program. There were 57 local facilitators, and the dropout rate was low. The attendance was high by these very busy people, indicating that this program is generalizable and is potentially a model for others. Our points of departure for the program were that physicians' professional identities, who I am, continues to develop throughout adult life, and that growth in medical humanism is often inhibited in residency training by unsavory aspects of the hidden curriculum: isolation, overwork, poor role models. And this could be restored and reinforced in the setting of a small group learning community. So we are aiming directly at improving the professional identity formation of our faculty. That's our goal. We believe it will occur throughout life, and we want to create conditions that will allow it to flourish. This was our one-year curriculum. I can't read the entire curriculum, but you can see that there were many basic skills of teaching and role modeling, such as bedside teaching, feedback as a teaching tool, role modeling. There was a strong reflective component consisting of narrative reflection and other exercises like balance groups. And there were certain topics such as mindfulness, burnout, implicit bias, boundary issues that were also included. By trial and error, I've been working with these types of programs since 1985. And over time, developed this learning theory, which I published about 5 years ago, as to how the programs work and why they are, in fact, effective. We use reflective learning to enhance self-awareness and enhance the trust and safety and support in the group. We use experiential learning to enhance the skills, deliberate practice of the skills that we think are important with coaching and feedback. We use a longitudinal program to allow time for these things to develop, and we use a group process of support from the group to reinforce the synergy between reflective learning and experiential learning. We evaluated the program in several ways. First, using a survey, which was developed by our group with a good bit of help from Tommy Newey at Indiana. I won't read all of the features of the survey, but I want to read 2 questions to give you an example. Inspires me to grow professionally and personally. Now notice there was a 10% improvement compared to controls, and this was highly statistically significant. That is a personal quality. It is a character virtue. Actively uses teaching opportunities to illustrate humanistic care. 15% improvement, highly statistically significant. That is a skill. It's a skill that we explicitly taught in our program. Now, every single one of these, there were 10 questions, was statistically significant, and the overall was statistically significant. We repeated this with 10 additional schools, different schools, and published this separately with Calvin Chow and others that participated. A bit larger study, very well matched for gender, age, and specialty, and for overall standard teaching evaluations. So the controls had the same teaching evaluation scores as the participants, but not the same humanistic scores. And once again, all 10 of the items favored the participants, and the overall p-value was 0.019, statistically significant. So what we can conclude is that definitely our participants are superior in these humanistic character virtues and skills. whether there's any bias in this remains a question, because we couldn't control for everything. This is a cohort study. It is not a randomized trial. But we're interested in the development of the professional identity. And we looked mostly at the narratives at the beginning and at the end of our program. We looked at a series of narratives. The first of these I collected at a workshop prior to beginning the program. Someone gave me this amazing story about accompanying a great professor with a pageant of fellows, residents, and medical students who went to interview a patient or see a patient. Somehow, the words tumbled out, and this patient described her agony at having experienced the complete wiping out of her family during the Holocaust. When the professor turned to see the pageant, there were tears rolling down his face. The comment of the person who wrote this was, "That's the day that I learned to be a doctor." That was a profound seminal event which is carried with that person for the rest of their life. But there is a problem with that. The problem is we don't always have the great professor. You may not be lucky to be there on that day, and you don't know how he did it. And all of them said, with a comment at the end was, "I don't know how he does that." Well, we know how. We know how to teach that, and we want to teach that to the average teacher. So by the year 2000, we could collect stories of assistant professors who were doing activated role modeling and reflective learning in the clinic with regular medical students, and they were demonstrating the same kinds of things and having the same kind of lifelong impacts. By 2011, we had a group where there was transformative learning that took place. There was one particular person in the group who wrote an amazing story of having a patient who became very frightened over taking a test. The faculty member decided to also take the test just to experience it. This person also became quite frightened. And the result, when the test was negative, was a profound sense of communion with all of the patients. A new kind of empathy for the sense that we're all one, we're all alike, we're all in this together. And believe me, when this story was read to the rest of us in our group, we too experienced transformative effects. And by 2016, Richard Frankel and I collected narratives and showed that by the end of our faculty development year, we were collecting a different type of narrative called the formation narrative, which we think illustrated, at least at the time of the narrative, a very high level of professional formation. Here's an example. A 22-year-old young woman presented with fevers and night sweats, a left groin mass, consistent with acute infection, and became very frightened. "I don't want to die." The parents were standing by, very emotionally affected. The doctor, who knew the prognosis was good, knelt down beside the patient, held the patient's hand, and told her, "You are not going to die," and then went on to explain what would happen. The following day, with her medical student, the physician ran into the patient's mother. And the mother said, "I really liked how you talked to my daughter, and thank you so much for taking the time to explain." So as they left, this faculty member turns to the student and says, "This is why I love medicine. This is why I went into medicine." I love what I do. So here, the patient is profoundly benefited by a humanistic act which may have been beyond the capacity of this physician prior to all of the learning that she did in the past year. And the patient benefited enormously, and the physician benefited enormously, and at least at that moment was at the very peak of professional identity formation and development, according to what Keegan has defined as the development of professional values. This is the symbolic image of that. It's called the birth of the universe, and I would say the internal birth of the person. Now, we move to the organization. The organization, we did another study where we tried to define culture. And we came up with these 4 elements. The elements include 2 that we talked about. There's all of this, role modeling, we just talked about. The organized activities, I just told you about our organized activity. There were many others. There's the Healer's Art course, for example. There's the Gold Society, many, many other organized activities. But we argue they are not sufficient. It also, in order to overcome this disparity between the humanistic tradition and the business model, we need 2 more things. We need supportive leadership, and we need a facilitative practice structure. The memo study by Mark Linzer validates our findings. I'll only talk about the validation part because the rest of it pretty much I'll talk about later. But Linzer enrolled 420 physicians, and his results, like ours, showed the same thing. 61% were stressed. 38% said the practice was chaotic. 27% were experiencing burnout. 31% were likely to leave. The major conclusion had to do with the propensity to make medical mistakes in this environment. Linzer went on to study some changes, but I think they were pilot studies, and they fell short of the kind of profound change that we are looking for. Another approach was taken by Joe Shapiro and Andy Whittemore at the Brigham. They formed a Center for Professionalism, and they put on an educational program for 1,287 physicians at the Brigham. And you can see their sessions were very different from ours. Our program is entirely positive, but they addressed harassment, bullying, managing conflict, and the range of unprofessional behaviors. When people were reported to them as having had lapses in professionalism, they engaged in a program of remediation. They did not do discipline. The outcomes were that 78% of the people remediated went back to successfully perform their jobs. 11% left due to the issue. 5% were demoted. This was done by the department chair, not by Shapiro and Whittemore. They only did the remediation, but I will say this. To do a program like this, you would have to have a Joe Shapiro and an Andy Whittemore. Having been at the Brigham, I can tell you that there's tremendous respect for those 2 faculty members. And they can carry out a program like this because of the trust and respect. It's a different approach than ours. Now, what about changing the practice? Let's come down to the bottom line here. How do we make practice better? How do we overcome these barriers? I think Christine Sinsky, who is now at the AMA, is the person at the cutting edge of this. She's done observational studies on a number of practices and found these disturbing data. The physicians spent only 27% of the time in direct communication with patients when they were in the room, but 49% of the time in direct communication with the computer, and the other 24% with desk work. The average physician took 1 to 2 hours of paperwork and computer work home at night, every night. She said it would cost about $1 million to replace a primary care physician. I would have to add that Linzer thought it was $250,000. And having been the previous division chief at Emory, I would say it didn't cost us anywhere near that much, because we had so many people that wanted to be a part of the faculty. So it's variable at different institutions. And I'm not saying we don't have any of these issues, but I am saying we were, by the way, not part of this study. And I see that we do some of the things that are being recommended. But the primary care physicians were thinking of leaving because of the chaotic environment, their lack of control over it, and their burnout. Now, she said to address the chaotic environment, there are a number of things that could be done. You could plan the visit ahead of time so that everything was done that could possibly be done, including writing the refill prescription so they only had to be approved, doing the order entry and medication reconciliation, which is a time-consuming task, getting the lab tests and getting the results. And also, you could provide scribes or some other system to actually document at the computer during the visit, freeing up the physician. And so Sinskey is now doing these pilot studies. And I think they're pilot studies, and I don't think we know enough to know how they will work out. But she says you can save 1 hour by doing all of those pre-visit things for every 2 hours of patient care. This pre-visit program, you don't chase lab results because you already have them. You don't write prescriptions because they've already been written, and so forth. Saves 1 hour for every 2 hours you are with a patient. And the physicians are more satisfied. You can do 25% more visits if you have two or even 3 high-level assistants to help with the flow and with all of this pre-visit planning. And then there is the 4-part team model. Now this is going to require 2 highly trained assistants, such as a nurse. And it works like this. The nurse meets with the patient, gathers and organizes the data, including the patient's, all of the information related to the visit, including the patient's history and complaints. The physician enters the room and reviews in front of the patient with the nurse everything that's been gathered. Then the physician verbalizes changes in the plan and leaves and moves to the next patient and the next nurse. And then the 4th part is the nurse organizes these changes, educates the patients, makes sure they have all the prescriptions and appointments, and then moves on to her next or his next patient. So this type of organization using 2 assistants can create enough extra time to see enough patients, and it only requires about 2 more patients per day to pay for the whole thing, and you have patients that are more satisfied, physicians that are more satisfied. Other reforms that Sinskey is recommending include basically better communication among the support staff, where they are located next to each other where they communicate verbally rather than by email, and whereby they have a team and they have briefings, debriefings, and huddles. So there are plans going on now, there are pilot studies that have great promise to change the practice. Now, having sat on both sides of the table myself, I've sat on the business side and I've sat on the clinical side. And I know exactly how it feels on both sides. Change is risky. It's frightening to make big changes if you're on the business side, because if they don't work, it could be a very bad outcome. So, the structure and culture of an organization crosscuts these motivating and inhibitory factors that we study for humanism, for the tradition of humanism. The incongruence between medical professionalism and the business of medicine could be reaching a crisis stage, at least in many institutions, from what we saw. But we also saw some other things, strikingly absent when we studied the leaders and when we asked the physicians, was language describing change agents who could articulate and model a clear vision for how to reshape and improve the organization. The physicians were fighting individually, but not joining with their leaders to create a culture of safe, excellent, efficient care that also preserves traditional values. So complex organizational cultures are co-created. Organizations resist changing. Change may occur from the bottom up. The first step in a positive change, we call this adaptive change. It means you're not making little tweaks. You're thinking out of the box, thinking of a totally new way to do things. And the first step is to reach a consensus on the mission, the strategy, and the goals of the organization. And that doesn't mean a top-down mission statement that someone writes and then says this is our mission. That means a consensus that includes both the people on the front line and their leaders at various stages, and the colleagues they work with in other professions, what I call the wider community. And this presents a challenge because in our studies, the participants identified only some humanistic leaders that were doing these kinds of changes, and they never mentioned a common vision. So, at a time of crisis, the basic steps for organizational change, at least at the time of this study and in these institutions, seemed absent. There were some comments about good leaders. Humanism is promoted by my division chief. She treats all faculty with respect. She sets the tone. Because of this, we are better able to work as a team. We support each other, cover for each other. We are given a reasonable time to see patients and a reasonable number of sessions per week. It is my goal, as a sort of a sub-chief, to maintain this supportive environment for all the staff in our clinic. But for every comment like this, there were many like these. They do not listen. They prioritize RVUs. The focus is on productivity. There's no value for taking the time to be humanistic. There's a lack of communication. They don't have an understanding. We're asked to adopt too many initiatives. We're understaffed. This can create stress and negativity, leading to a less humanistic culture. And we go back to the idea of professional development which was outlined in 5 stages by Keegan. And I want to look at these just briefly. In terms of values, stage 4, this is supposedly where all of us are in Keegan's model. We're all at something he called the self-authoring mind, where we choose our values and they become internalized, and we are idealistic and self-reflective. Go back and look at the comments at the beginning, the sustaining comments, and I would argue that's where they are. But if you look at the social role, this is less well developed. It may be developed in our leaders who are problem solvers and create strategies. Our leaders may be at stage 4, but many people that we collected comments from may be at stage 3, seeking direction. The argument here is that we need to move to stage 5. We need to move toward stage 5. Stage 5 in Keegan's model is very hard to get to. Only about 4 or 5% ever do, usually in the 40s. But this is a transforming stage. You're open to the values of others, and you can step back. You discover your blind spots. I attribute this to Linda Lewin, who is an expert on this, on the Keegan model. And you can understand the viewpoints of other people as well as your own viewpoints. You understand the different expectations in relationships. To put this further, the stage 3 social role person is a team player, striving to do what is told. The stage 4 person creates and directs traditional strategy. The stage 5 person steps back, considers alternatives, understands the values and expectations of others, is non-defensive, controls emotions, and is proactive. So we're going to end up saying, we think from the educational viewpoint, we need to start moving people much more effectively upward in their social role formation in the community of practice. This is a goal of medical education. And we need to move them toward stage 5 because the challenges of the future will be huge. So, this is what our data suggests, that we need to move in this direction. And we have moved our program to an interprofessional program. And here are some preliminary results which I will end with. What were the themes of the interprofessionals, which included physicians, nurses, physical therapists, and others working together in the same program that we had for the physicians that I showed you before? They were deeply engaged with each other. I learned about other professionals who have the same fire and passion. I did not realize that social workers and nurses also have a calling to serve patients. They have their own stories to tell. Their attitudes changed. I have been challenged to look at myself to make our team more effective. Their perspectives changed. I have seen firsthand the amazing aspects each colleague brings to the table. And they developed a strong sense of community with each other, meaning the wider community beyond the small physician team to the wide community of all colleagues and administrators and patients and families that are involved with us in this mission to relieve suffering. I have grown to admire and respect the members of this group for who they are, their experiences, their honesty, and their vulnerability. So, with effective changes and adaptive changes in the way we manage practices, a new paradigm for how practice will work, with a change in education towards developing the social role, identity of the physicians and others in the healthcare community, we can succeed in maintaining the kind of compassion and empathy and focus on patients that's always been the tradition of our profession. Thank you very much.
Sure, all of you have some questions here we'd like to ask Bill, and so I'll open it up. I guess my first thing is, how receptive is the administration and division heads and leaders in the community to your message? You've got an important message to give, and do it well.
It's a little too early to really give you an answer. I will say this. When we studied leaders, we collected data from the leaders, which is coming out very soon. They were very sympathetic with the frontline physicians. They understood the pressure. They felt badly about it. They wanted to start these programs like resilience and mindfulness. They wanted to be supportive, but they didn't show a full awareness of the need for transformative change in the practice. And I think that's the step that we need to educate. All of us need to be educated on that need and the willingness to step forward and start doing these things.
Okay. Questions?
I
guess a follow-up question I would also have is that the importance in of getting this message out, and all your colleagues in other med schools, is a general consensus that the leaders at these other schools have bought into this, or is it the same situation? Too early to tell.
Again, we're at a very preliminary stage of just sort of discovering what we think is going on under the surface of all this data, this big data that you see of 30 or 40% burnout and chaotic environment and people leaving and retiring early and so forth and so on. So we're very early. All I can tell you is that the AMA has hired Sinsky, and all of these pilot studies are underway. People are beginning to think of these solutions. People are beginning to try them in different places. And I think what we see among leaders is that they too realize there is a problem. And so that's the first step. And so we know the leaders are sympathetic. We know they realize there's a problem. I think that they will be supportive of making changes. But I think it's too early for us to really know. We're still in the point of trying to publicize what we have, write papers, get them out, give talks, and so forth.
You gave the message out.
I hope the message was given out. Thank you very much.
I have one question from Grady real fast, sorry. I'm just going to read it verbatim. It says, I noticed that none of the actors of humanism, or none of the stories of humanism involved an actor other than the physician and the patient and occasionally family members. I think this makes sense in light of your finding that physicians see themselves largely as isolated saviors and that perhaps most participants are Keegan stage 3. Yet medicine is inherently interdisciplinary and many professionals touch patient care, and these professionals have a lot to say about humanism and empathetic patient care. This seems key to moving to stage 5. Your formal education unpublished data on this was very interesting, but what should we be doing not as interdisciplinary team leaders, but as team members at the bedside in the moment to improve empathy and humanism at the point of care?
It's a very big question. I could give
a large
lecture. A good statement. Let me just say, it's true. We haven't yet published our data from the interprofessional studies that we're now doing. That's where we are now. We're collecting the same kind of data from interprofessional groups, and we're getting lots of quotes from nurses, physical therapists, midwives, nurse practitioners, physician assistants. They are the same the same kinds of thing that we've been getting previously from the physicians. So we're not going to see a difference. Whereas, as I said in my last slide, what is potentially possible is for all of these people in the different professions to learn to understand each other, to trust each other, to know and respect each other at a much higher level than they currently do, and to work together as a real high-functioning team in order to deliver care together that's much more effective. I think we see the potential, and I think that's what we are now moving toward and what we have to incorporate into our educational programs. It will work. We've already seen that it works. So I'll just answer that one part of the question.
Thank you, Bill. I think you've shared a lot of wisdom, a lot of knowledge with us, and we certainly appreciate it. Thank you.
Thank you.